Welcome to episode 26 of the Normless podcast. I'm Simon Rosenbaum.
Welcome to the podcast, Simon. It's a pleasure to have you all the way from Colombia. I was just saying before we came on air, you're our second international guest, and it's really funny because it's 11 o'clock here where I am, so I'm in my pajamas all ready to go to sleep, and you're just woken up ready to go. So yeah, thanks heaps for giving up your time, mate, and I'm sure this will be a really interesting discussion.
Thanks for staying up late, Hayden. Really looking forward to chatting.
So tell us a bit about what you're doing over there at the moment.
Yeah, so I'm here in Colombia, I spend a bit of time at universities here and working with a different group of people here. I've been coming back to Colombia for a couple of years now. And for me, it's one of the most exciting places in the world around mental health physiotherapy and this idea of linking body, linking mind, physical activity, and the mental health physiotherapists here in not just Colombia, but across Latin America have just got so much experience and knowledge and different ways of doing things. So I've been really fascinated by what's happening here and really excited by the not just the work they're doing, but the way they're sort of mobilized as a profession, as a group, as a collective. Yeah, it's a really exciting place, and for the work I do, there's nowhere else in the world that I'd rather be than here at the moment.
And how do you keep yourself fit when you're traveling around? So where do you find the time to fit in your physical activity? Because you got to practice what you preach, don't you, mate?
I was hoping you weren't going to ask that. I'm a bit crook this morning, to be honest. I do struggle when I'm on the road. I had a crazy flight because before I came here, I was in Jakarta teaching for a week, and the only tickets I could get from Jakarta here to Bogota went via Doha, Madrid
Oh,
to
wow.
Bogota. So it was just a journey around the world, and I did get a bit sick. So yeah, I struggle. I do try to do as much as I can, but the thing for me is food, Hayden. I really struggle with maintaining, eating enough and eating good food and trying not to get sick. So yeah, it's not sustainable long term, I think.
I imagine it's all about like incidental activity. So just making sure you're moving around, but you're probably
Yeah, it's
not putting
hard
enough
though.
energy in. So
Yeah, it's hard. I mean, I struggle a little bit sometimes because I lose weight so quickly, and that becomes really difficult and when you're not on a routine, you can't do the shopping or you can't cook. But yeah, it's short-term sacrifice.
and you just briefly touched on it there a bit about the link between psychology and physical well-being, physical health. And for a long time there's been a disconnect between the two. I guess ironically in my own experience and yours too, going to UNSW, you had the health sciences building and then the psychology building on the complete opposite ends of the court there, really. And when we look at things now, very much they should have been almost integrated as a whole. That misconception that mental illness is not a physical disease. Um, we now understand there's a direct link between the two, and subsequently it'll impact your physical health as well. So this episode is titled "Exercise is a Human Right," and we're going to talk a lot about what inequities exist, some of the barriers to being more physically active, and how improving your mental well-being can directly improve your physical well-being.
It's all totally linked, isn't it? Look, it's yeah, and that's been the basis of our work for a long time. I guess to break it down, if we think about people living with mental illness, whether that's post-traumatic stress disorder or schizophrenia or depression, we know that people are less likely to engage in physical activity. We also know that less physical activity is linked with poor mental health. So there's kind of this cycle there. And for me, it's thinking about we know that when we get the opportunity to move our body and to participate in some form of physical activity, it can help us to feel better. That's the basis of all of our work. It's very, very simple. But what we know is that the people that are most disadvantaged or excluded from society, and that includes people living with mental illness, are often the least likely to have access to supportive environments, safe environments, free, accessible environments, whereby they can participate and achieve those benefits that the rest of us can enjoy. And so what I'm, talking about there is things, some of the barriers that we don't necessarily consider, things like having access to shoes or having access to safe footpaths, or a safe environment where you can walk down the street to participate in activity. The physical activity guidelines, say, look, aim for 150 minutes, but there's no recognition of, is that possible? There's no recognition of context, of culture, of financial barriers, those things that actually, there's no point health professionals saying, hey, go and do some exercise to, big parts of the population, that it's a privilege, it's a class privilege. And so how do we break that down?
Yeah, and so I was on doing my research, and I was on your Twitter. I don't know if we still call it. Do you still call it Twitter or X?
Yeah, Twitter, I think.
Yeah, and there was a video that you recently posted. Exercise shouldn't be a privilege when our health is a human right. I think that's a really, really good quote, really impactful. But what you just said there about some of those barriers, the need for a gym membership, social support. So I guess you see a lot of gyms these days with creches, so that mums have the, I guess, recreational time to do a bout of exercise. The need for mental health comes into that category as well. And we know that 1 in 5 Australians are dealing with some form of mental illness. And I think it's about 2 in 5 for, people between the ages of 18 to 84. So there is a large burden of mental illness in Australia. So why do around 20% of Australians face these mental health challenges?
Yeah, there's these great cartoons that I use in lectures sometimes, which they say, imagine if we spoke about mental health the way, or sorry, imagine if we spoke about physical health the way we speak about mental health.
Yeah.
And they're cartoons, and one's got a picture of a guy who's just chopped his arm off, and and there's blood gushing out, and his friend is saying, look, I understand, but I think you just need to change your mindset, and things might be a bit different. Another image is someone with food poisoning, and they're in the bathroom being sick, and their friend says, I just don't think you've even tried today. And I think those cartoons are, for me, they're fantastic, because they point out the hypocrisy, the way we think about mental health or physical health, and the fact that we can't see it means that we have these different ideas around what it means and how it impacts people. But these are illnesses the same way that physical health conditions are. Now, it's not to say that all distress is the disorder. There's normal range of human emotions. There's also different points in time we can all feel, better or worse, or have symptoms of, we might feel a bit anxious or we might feel a bit depressed. That doesn't mean we have reach diagnostic criteria for an illness. So I think there's a lot to be done around, mental health literacy. But I know, like, some of your previous guests are doing fantastic work around breaking down stigma and encouraging people to talk, and some of Gus Wallen's work and that sort of stuff. So I think, there's lots of reasons to be optimistic around how we're changing the conversation about this stuff. And happy World Mental Health Day today as well. So,
Yeah.
there's reasons for optimism, but I think the physical health link is something that we're still lagging a little bit on, and having that discussion.
Yeah, I guess looking back on it, and I was only just talking about someone about this the other day, but in all the guests I've had on the podcast, more than, I'd say, 70% of guests have had a story about someone in their life close to them who has tried to commit suicide, or they've tried to commit suicide. And, I think there's a lot more people coming forward now to talk about, which I think I'm going to talk about in a moment, in terms of, the increasing prevalence of mental illness. Is it the fact that people are opening up to it now and they're more willing to talk about their burdens? Or is it just that, our mental health status is worsening? So that'll be interesting to hear your thoughts on too. So do you think it is more so that people are willing to talk about their struggles, or do you think we are, struggling with, coping and with this ever-changing world?
Yeah, I think that there's probably a bit of both. I think as we start to have discussions, as we start to break down stigma and create pathways by which people can come forward and have these discussions, you're likely to get more people reporting, which is great. Um, I also think that what we know around the link between what we call modifiable lifestyle related factors are things like activity, things like screen time, things like sleep, nutrition, social connection, loneliness. Those are all factors that we know can be linked and associated with. They can be protective factors, but they can also be risk factors. So I think there's a long way to go around not necessarily jumping to the medical conclusion or thinking about the medical approach, but thinking about what can we do around those sort of first line lifestyle factors. What can we change there and modify there that might actually impact the trajectory of an episode or a disorder? So what I mean by that, I'll give you an example. I've done a lot of work in post traumatic stress disorder, and what we know in PTSD is that over time, people's symptoms uh, increase. So those with the most symptoms tend to have the biggest drop off in physical activity over time.
Yeah.
And this is data from a 20-year longitudinal study. So in other words, we can see there that inactivity or becoming inactive can be a risk factor. So it raises this question about if we were to intervene early with people that are potentially at risk, and by intervening with things like physical activity programs, social connection, nutrition, food, staying away from alcohol, does that change the trajectory of PTSD? Now, the evidence tells us that obviously not all cases, it's not a cure for everything. It's really important I stress that I'm not saying if you just sleep well and go to the gym, you're going to cure mental illness. That's not the case at all. But the data we have tells us that for some cases, we can probably, considerably change the trajectory of that illness.
Yeah, I think it's something that definitely can be said for a lot of these non-communicable diseases as well. You look at diabetes and we think about once someone's diagnosed with type 2 diabetes, the first thing that a GP will do is prescribe them, 500 milligrams of metformin, as opposed to writing them a team care arrangements plan and saying, go see a dietitian, go see your exercise physiologist. So I think it is a really important point you make there, isn't it?
Yeah, and I think it's an interesting, I'm interested in your thoughts on this, but there's almost, we know in mental health, there's been this nihilism around,
Yeah.
this idea that, well, you know, we could write that team care arrangement, but is it actually going to do anything?
Yeah.
And this is where I think that's what I'm really interested in is, well, why are we failing to create something that does work? Why are we failing to create a referral system that actually supports that person to participate? Um, so that to me, I think that you're right. It applies across diabetes, across the range of NCDs. But I think there's a lot of work to do in terms of, yes, we have this referral system, but to actually making it useful, making it appropriate, and making it safe for the people that we're trying to reach.
Yeah. And I think they've made some changes too with the mental health plan. I remember during COVID, they increased that to 20 visits per calendar year, I think it was. And then now that's dropped back to 10, I think even less now, but there's a new requirement where you actually have to follow up with your counselor or psychologist in order to get access to the further sessions. So I think there is that also that element of the government, especially after the COVID period, trying to really tighten up in terms of their healthcare expenditure. And I was talking at a recent seminar with regards to some people living with type 2 diabetes. And around 9 or 10 years ago, they used to Medicare used to subsidize dental care for people with type 2 diabetes. But because the GPs weren't writing these referrals and no one was accessing these rebates or these subsidies, they got rid of it. And so I think there is a potential push to, if no one's using, like, for instance, the type 2 diabetes group allied health management plan, just to scrap that. So I wonder whether what you're saying is correct in that, GPs maybe see it as something it's there, but it's not of, immediate or innate requirement in order to change their mental health status. And so they're not referring their clients to see a psychologist or a counselor, and therefore, the government's tightening up on healthcare expenditure despite the problem getting worse.
So, I really resonate with what you're saying, because a big focus of my work at the moment is around like the workforces. So thinking about the mental health workforce, and then thinking about the physical health or physical activity workforce and nutrition,
Yeah.
and thinking about what do we need to bring those two together. So we're doing a lot of work training, the physical health, so training exercise physiologists, physiotherapists, dietitians in mental health skills, and then thinking about, well, what do we need to do to train the mental health workforce in physical health, physical activity and nutrition skills, and then how do you build referral pathways between them and bring them together. And one of the really interesting things thinking about those referral schemes that you mentioned, is that we know there is a huge shortage of mental health professionals. So the waiting list of people waiting for counselling or psychologists is enormous. Um, we do have a physical health workforce that is essentially ready to go, that could be mobilised to be providing nutrition, exercise support to people living with poor mental health. Imagine if we had a system whereby someone, gets a referral to a psychologist or a counsellor. During that waiting period, if they're waiting 3 months to access that person, why can't they get some support with their physical
Yeah.
health in the meantime?
Yeah.
Now, at worst case scenario, you improve physical health outcomes. Best case scenario, and again, this is, if we look at the treatment guidelines for depression, it's very clear that for some cases, so not for some cases, for all cases, but lifestyle change should be recommended as the first line strategy. But acknowledging that for some cases, so for mild to moderate cases, lifestyle change may be enough. So I just think that we've got this huge opportunity to think about relieving a burden on the healthcare system, improving physical health outcomes, by thinking a bit out of the box about what is a mental health practitioner, or who contributes to providing mental health care.
Yeah, and I think going back to what we talked about before with barriers, and you mentioned briefly the physical activity guidelines in Australia. And if you think about someone who's dealing with anxiety or depression, likely they don't have the same extent of motivation as we do to, go and exercise on a regular basis. Now, if they're not meeting those recommendations, it's likely they're going to be disheartened to do nothing at all. So do you think in that respect, with the physical activity guidelines, there should be a push to incorporate some guideline that is, if you can't meet 150, 200 minutes per week of cardiovascular or physical or aerobic exercise, something is better than nothing, or something along those lines, to make people, because people can be very hard on themselves, especially with diet as well. You've seen no doubt, a lot of eating disorders in youth, and if someone's not meeting those guidelines, they must feel like a failure to some extent, and that's really going to hurt their self-efficacy, and their likelihood of engaging in physical activity.
I'm just vigorously nodding along everything you're saying. So yeah, of course, the shame is a factor.
Yeah.
So if people are not meeting these guidelines, shame can be an issue, and also the idea that the sense that unless we're achieving that 150 minutes, there's no point.
Yeah.
So Megan Teixeira is an associate professor at Deakin University. She's done some brilliant work on exactly this topic, and she wrote a paper. I think the exact title was "Do We Need Physical Activity Guidelines for Mental Health?" And that was published in Mental Health and Physical Activity. But articulating exactly what you've just said, and the idea that we need to consider that these guidelines are often built around epidemiological evidence for physical health issues. They don't consider the idea that if you are experiencing poor mental health and you manage to find some motivation to go and do a couple of minutes of movement, to get out of bed, to do something, that can be beneficial. So yeah, what you said around something can be better than nothing, I think is really important there.
even like 10,000 steps a day and the research that was coming out of, in order to reduce more mortality risk, I feel like that can cause more mental illness than it can prevent, in the fact there's like analysis paralysis. You're like checking your monitor every day, and if you don't hit those numbers, you're depressed for the rest of the day, and then the next day you hit 15,000 and you're all merry. So yeah, I think there's something to be said there for those guidelines, and maybe making some amendments to facilitate people's expectations based on a lot of people's lifestyles. Don't if you're a truck driver, you've only got limited time throughout the day to be on your feet. So we've got to start to make some guidelines that work in accordance with, I guess, different people's lifestyles and occupations as well.
Yeah, I think that's really fair. I think that's totally fair. And I think WHO have done a good job, particularly in the recent updates, of incorporating mental health. And that was one of the first times that we saw mental health as a key theme. That's in the 2020 guidelines. But yeah, I think there's still a way to go around the real world implementation. But it's probably it's a balance. I understand from their point of view, they've got to look at the strongest evidence they possibly can, how that balances with the applicability to everyday people that are then hearing them. It's a balance, but I think there's more that we can do to ensure that those guidelines are informed by mental health and considerate of mental health.
If we drew up a bit of a Venn diagram and we had mental health on one side, or mental illness, and we had diabetes on the other side, and we went into the middle there and we looked at that overlap between the two. We spoke briefly to Drew Harrisberg a couple of episodes ago, and he's living with type 1 diabetes. And fortunately, he hasn't gone through a lot of diabetes-related burnout, which often occurs during that transitional period, when they're leaving, when an individual's leaving school and they're going out into the workforce and, studying, and they're developing independence. And they have all of these, continuous glucose monitors, insulin pumps, and these devices that are giving them alerts, and they have to monitor what carbohydrate they're putting in their body, the amount of activity they're doing, stress levels, sleep, and all that kind of thing. That's been linked to causing a lot of anxiety in people with diabetes. And then on the flip side of that, we look at a lot of the medications that are used, like antidepressants and anti-anxiety medication, which can have a direct impact in some circumstances on increasing hyperglycemia or glycemic control, but also leading to potentially weight gain as well. In terms of, I guess, some of the barriers in that respect, we just talked briefly about how some people living with mental health conditions that aren't meeting the guidelines will feel disheartened. In your own experience, how have you found weight as well, like a weight-centric focus, has impact your treatment outcomes if people are focusing on the scales as opposed to those more, subjective, like how you're feeling, well-being wise, pain management, but also intrinsic, feelings of self-esteem, self-efficacy, and then blood markers as well?
Yeah. Where do I start with that? It's a really good question. Yeah. So at the moment, if I just pull it back a little bit, the focus of my work, so I'm an exercise physiologist by background, but all my work at the moment focuses around social exclusion.
Yep.
So what we mean by social exclusion is it's groups that are exposed to adversity, or an example would be refugees and asylum seekers. It would be people experiencing financial hardship. It would be people who have been exposed to gender and sexual-based violence. Now, what we're trying to do is to provide some, essentially the momentary relief and joy that movement can bring to those people. Now, in a safe, accessible way. So I guess the point of what I'm saying is that weight is just not even a consideration,
Right.
when we're talking about the benefits of movement and activity for groups like that. we're not interested in weight. It's not even something that we would measure. It's not something we'd look at, because we know that the mental health benefits of activity can come independent of any change in weight. Um, so we know, and I think it's been problematic. The link between body weight and exercise is problematic for me, because if you ask people, and we've published data on this as well, the main motivating factor for commencing an exercise program is often weight loss. Now, we also know the data around exercise and weight loss without thinking about your diet. So without changing your diet, it's not very effective. So we're setting people up to fail there, and there's a disconnect between what we're measuring and what we're doing and what the likely outcome is going to be. So in short, I'm not interested in body weight. I'm interested in how do people feel? How are they sleeping? How are they moving? How is their anxiety? Those sorts of factors that we know can change or shift in response to some activity, as opposed to body weight.
Yeah, I think you spoke to Anita in the Good Chat. I was listening to one of the podcasts you did with her, and this is something that you got quite a strong stance on in terms of that. And I guess success leaves clues, doesn't it? So if your research, you've and the work you're doing, you've steered away from even touching on that, focusing more on the things like sense of ability to engage in activity, a sense of autonomy and competence, and ability to take on different skills and be able to exercise a good quality of life through just being able to move more and
Yeah.
sense of freedom. Yeah.
Because I think what we don't think about, what we often fail to think of, is, for those of us that have had the privilege of being active, or being in those environments, there are a lot of people in society that have been excluded or not welcomed. And that's either deliberately or implicitly or explicitly. And what I mean by that is it could just be people that they don't see people like them in those environments.
Yeah.
Now that's problematic, because then if we think about how stressful that can be for someone to turn up to one of those environments, and then we add these additional layers of, right, now we're going to poke and prod you and look at a number on a scale. Of course that's going to be a deterrent. So I think we've this idea for me around safety in providing, if we're thinking about providing physical activity services. And safety is not just physical safety, but cultural safety, emotional safety, psychological safety. How can we actually create those environments that can support people to be able to participate?
Yeah. And I guess for anyone who's interested, who's listening, just to put into perspective, I've just done a little bit of research on some of the papers. Now, Burke and et al., this paper's quite an old one. I'm going to, if any references that you want to throw up throughout or send me through after this, I'm going to put in the show notes so people can read. This one here had a little bit of data on tricyclics, and they're a common class of medications used for depression, anxiety. So an average 6-month treatment on this medication produced a weight gain of around 1.3 to 3 pounds per month. And then other forms of medication, so selective serotonin reuptake inhibitors, or SSRIs. One that you're probably commonly aware of is Zoloft, for instance. These inhibit basically the uptake of serotonin, the reuptake of serotonin, so that basically more serotonin is in the brain to promote their mental health. Now, this also is one of the classes of medications which has the highest risk for weight gain. And then there was another study that was published where around 300,000 people, 300,000 participants, there was an 11.2% of these participants had an average body weight increase of about 5% within the first year of commencing intake of these medications. So there is a potential there for people who are, I guess, in a more clinical setting to focus on that weight gain as an outcome. We look at things like BMI, which is essentially dynamic between height and weight. And, you know, your height's typically not changing much throughout your life, year to year, week to week, unless you're an adolescent or growing individual in their youth. But you look at those two, and basically it's a function of height and weight. And, you know, if you're commencing an 8-10 week exercise program and you build some lean muscle tissue, it's likely that you're going to lose some fat mass as well, and your weight's probably not going to change too much. And if you're looking at the scales, it's quite easy for someone to become quite disheartened. So I know what we just spoke about in the work you're doing, but I guess for anyone out there, I guess in a clinical setting, or for those that are dealing with any mental health conditions, what are some markers or parameters? We spoke about a few of them, but you would advise that people would look at more commonly? I think one you spoke about with Anita was a scale of 1 to 10, on just a really easy subjective scale on 1 to 10, how good you feel on a daily basis, or keeping a little bit of a journal. What would you recommend for anyone listening?
Yeah, really, really important points. I think the first thing to just mention is that medication is nothing to be
Afraid of.
shameful of, or nothing. We don't need stigma. We shouldn't be stigmatizing medication at all. I think what you pointed out is really important, these side effects of medication, but we need to acknowledge that there's a lot of people that need the medication.
Yeah.
And the medication serves a role, and that's absolutely fine. So I think it's just to stress that sometimes there has been a bit of media recently about the idea that, well, exercise might be better than medication. And I find those comparisons really problematic and unhelpful, and actually not what the evidence says. Yeah. So I think if we think about exercise, it's a tool in someone's tool belt. They may need other tools as well. So exercise can still be useful, but you may need those other tools. You can't just use a hammer for everything. Yeah. So that's the first thing. The weight gain and the side effects of these medications is not just antidepressants. We also see devastating metabolic, so devastating physical health consequences of antipsychotic medication as well. And again, these are really important drugs that people need. So the important thing is that the prescriber of those medications is monitoring that situation. And I'd really encourage people, if they're experiencing these side effects, or they're taking these medications, to have that discussion with the prescriber around the monitoring, because there are things that can be done alongside. So that's probably in terms of the steps that you can take. We know that activity can be really important, but what for me is always missing from this discussion is the how. We're always talking about the benefits, and exercise can help, and changing your diet can help, but we're always missing the how do we actually support people, particularly people that might be experiencing very severe symptoms, might be experiencing needing medication, living in challenging circumstances, and I think often we stop short of actually coming up with solutions around that. So the thing that I mentioned around the scale, that 1 to 10, is simply asking people, 1 to 10, how do you feel today? How do you feel right now? It could be during or after an exercise session. And for us, it was about shifting the measurement away from weight towards something that people can own, people can claim, and people can actually use, to start for themselves linking what might be happening in how they feel around what they're doing, and around their sleep, and around their movement.
Yeah, I think great point you make there. Definitely not saying that medications aren't necessary. I think a lot of the I guess responsibility lies on the health practitioners too, or the health professionals, to make sure that the message is, it's not about, stopping taking your medications. It's more about, how are you going to determine your exercise success? What marker are you use to define your exercise success? And I think if you're using the weight, you're basically setting yourself up for failure, for the reasons that we just discussed. So Simon, how do you get people moving who are clinically depressed? Hot and cold one day to the next. Some days adherence is a real challenge. We know that adherence and, the frequency of physical activity is really important to get the health benefits as well. So how do you keep people engaged and motivated, or
Yeah.
the tough one?
It's a really good question. I'm sort of having a moment of panic. Look, what I can give you an example. I can tell you a little bit of a story about a project that we're doing at the moment that for me I'm really excited about, and it's a project we've set up at the Addison Road Community Centre in Sydney. Now, Addie Road deals primarily with food insecurity. So they're this amazing charity on site. They have 40 different social services. So they have a food pantry where people who need discounted or free groceries can access the food pantry. There's legal services, there's domestic violence charities, there's all sorts of incredible social services. Now, we've now set up a gym, or a not gym, at Addie Road that we called Addie Moves. Now, Dr. Grace McEwen led some brilliant co-design work over a 12-month period with refugees and asylum seekers. So these are people who have been exposed to, potentially very traumatizing experiences, including forced displacement, as well as refugee services. And we're interviewing them about what do we need to create an exercise service that would support these people. And what Grace was able to put all that down into was 6 key sort of themes. And for me, it's those themes that actually, if we think about how do we create supportive exercise services, that this sort of covers it. And I know your question was about depression, but I think it's not actually diagnosis specific. I would say it's how do we support anyone, but particularly those that might be experiencing additional barriers or additional stresses. So again, and I've mentioned it, but the idea of safety, so cultural safety, psychological safety is absolutely critical. Now, a practical example of that is, does the exercise workforce that we're talking about, do they have any training in mental health skills? Do they have mental health first aid training? Do they have any additional training in actually how do you engage and talk to someone? How do you, identify signs of distress and what to do? Do you know how to refer someone? When you're promoting activity and working with that client, are you actually considering the unique experiences? Whether it's we talk as well about the social determinants of health, so the conditions in which people are born, live, work, play. That has a big impact. Are we just telling people go to this really expensive gym that you can't afford and you don't want to go to anyway? So that's a key factor. Another one is accessibility. It has to be accessible. Now, if cost is a barrier, we need to remove that. So we've made sure that the service we're providing is free. Now, that's obviously not possible for everyone to provide free services, but if we think about the health service, if we're trying to create something that actually supports people and cost is a barrier, then that needs to be addressed. And some other ones there around physical activity literacy. If we're talking about working with communities or people, as you mentioned, that are experiencing symptoms, have we actually taken the time to explain why and the benefits, or have we just assumed that people know and they want to engage? And that also comes back to some of the work you mentioned before around autonomous motivation, self-determination. And we know that one of the biggest predictors of exercise behavior long term is that people are doing it because they understand and value the benefits for themselves. They truly believe it. And I think your listeners will probably, people will resonate with that, because those that work in that area or participate in activity, they're going to be naturally autonomously motivated towards that. But not everyone is. So understanding that and thinking, how do we shift people? And another way of doing that is probably not putting them on the scale the first time they walk through the door, when they're already anxious, nervous, don't want to be there, unsure why they're there. And a couple of the other points were around social connection, and we know that's absolutely critical. So providing a space where people can connect and particularly with others that have similar experiences. And the final one was around accessing, so support to access basic needs. So if we think about, the service we've set up at Addy, we might have people come through that are having issues with, it could be the legal system, it could be with food security. But how do we make sure that our exercise practitioners know how to refer people to those other services and how to link in with those other services and when to refer? So that's a long-winded answer to that question, but I think that there's a lot of factors that we can do there as, if we think about as exercise practitioners,
Yep.
to create a safer, more accessible, better service.
It's amazing how integrated, and you don't think about all of these things, living in a country like Australia, no doubt you've had an opportunity to really see things from a different lens. A bit of a curveball for you. How would you define physical literacy?
Physical activity literacy, yeah,
Yeah, or
good
physical activity literacy.
question. I think it's around the so this is interesting across cultures as well.
Yeah.
I think it's just being aware that it's around the knowledge of understanding the benefits of activity and movement. Now, in different cultures, physical activity sort of means different things. Um, I remember I was working, we were doing a week of teaching medical students in Uganda, in northern Uganda, in a place called Gulu. And I remember having some discussions with the medical students there, and they were like, just sort of rolling their eyes at me saying, no, but hang on, obesity and inactivity is a sign of wealth. Like when we return to our hometowns, we get picked up and we absolutely don't walk because it's a sign of status. And so I guess the point is around not assuming that everyone's framing or understanding of physical activity and exercise is the exact same. And so we often might need to pull back and question some of our assumptions and try to start with that person in front of you about what does it mean to them? Why do they think this might be important? And how do we start shifting away from the idea of us as health professionals saying you need to exercise towards understanding what does that person feel about this? What do they need? And what do they think? And how can we maybe support that and shift that over time if needed?
Yeah, it's really, really interesting, that cultural understanding. And I think it's something I've experienced too. I was in Kapas, Tarlac in the Philippines last year around Christmas time. And, it was it's around the province, right? So it's an area where they're quite wealthy. And we're out in the basketball court playing with the locals, and, a lot of the boys rubbing around with their shirts up, rubbing their bellies. And, it's interesting, isn't it? That it's a sign of wealth. You're able to afford food, you're well fed, the wealthier parts of the world. But, coming from Australia over there, you're just thinking like, what's going on? Why? But yeah, I think that's really important point you make there, because I think something I spoke to about Kate Austin in one of the previous episodes as well. We were talking about, she has um, a charity, Pincher Poo, where basically what they're doing is they're providing like sanitary and hygiene based products for those in need, because there's a massive issue with hygiene poverty in Australia. Just talking about how giving tampons to some cultures is offensive. And we talked a bit about how, if you look, for instance, some Asian populations as well, if you look at Japanese people in the eye, sometimes it's perceived as rude. Whereas, for me, if someone was walking up to me that was Japanese, was looking at my feet, then I would think they're being rude by not, acknowledging me and looking me in the eye. So it is really important that we work to better understand cultures in order to break down those barriers, so we can foster better understanding to implement programs like you're doing with Addy Road. Yeah.
We're going to mess it up. I think the
Yeah.
really interesting thing about working across cultures is that you are going to F it up. And that's okay. It's about how can you respond to that and how can you use that as an opportunity to learn and then create. I think for me, if you can create a space or at least the aim should be to create a space where you can mess it up, and people will stand by you, give you another chance, or even better, tell you. And so that's an ongoing process that we all have to work on, and it's tricky because there's things that we just don't know.
And I think it's something that's like a lot of prejudice and racism can stem from as well. It's not necessarily the intention of the person. It can be simply just misunderstanding. In my perspective, whenever I do an acknowledgement of country, if you don't acknowledge the land on which, the people that from where you're standing, it can seem really insincere, especially if you're not of Indigenous descent. So I think it's definitely one of those things where I think it's also important, and potentially you've had experience with this, where when you go to specific countries, potentially you bring in cultural elders or to sort of help facilitate any of the programs that you're running. Is that something you've had a bit of experience with to sort of break through that
Yeah,
barrier?
look, I've been really fortunate to work in lots of different places and different countries. I think the first thing for me is that I'm always a guest in these countries.
Right.
So I'm very aware that I bring one type of knowledge. Yeah, so I'm here sharing that one type of knowledge, but they bring this other type of knowledge. That's if I'm in that country, it's even more important. So it's not my job to tell them. For example, I was in Indonesia last week lecturing there. I'm just sharing some examples about work we're doing, but then we had this discussion about, well, what does that mean there and what's possible there? And that's also how I think about if I was working with a client as well. I'm bringing one specific bit of knowledge to that discussion with that client, but they bring the expertise and the knowledge about them, about their situation, about their context, their culture, and that is equally as critical. And this idea of lived experience, and particularly within the mental health workforce now, is gaining much more traction and attention, and rightly so. The idea that we value lived experience, and that this concept about different ideas of knowledge and what is knowledge, because it's not just our university degree. That's one type. So I think that lived experience voice and that idea about valuing other forms of knowledge is absolutely critical, and that's how we're going to push this forward. That's how we're going to come up with solutions. Your question about people that might be experiencing major depression, or whether it's PTSD or schizophrenia, how are we best going to support those people is by asking them and by sharing knowledge where we bring one bit of expertise, but then we value and listen to their expertise and see how do we put that together.
I guess jumping back to what we were talking about before with the increasing prevalence of mental illness, we talked about how more people are likely willing to come forward and speak to their GP, potentially reducing resilience of young people, increasing distractions and technologies. One question I have for you, now anyone who's gone through uni and's done psychology 1A or likely have learned about the DSM-5, which is subjective classification system for the diagnosis of different conditions, right? Do you think potentially there is more likely with, if there was potentially reducing resilience of young people, going to their GPs and coming forward and saying, I have anxiety, I have depression, that there's this willingness to just diagnose people based on how they present rather than, an objective look at, say, the chemical breakdown in the brain. Rather than looking at things objectively, it's very much subjective based on this criteria as a potential problem in the current context.
You're drawing me into a critique of psychiatry here.
Yeah.
Look, a couple of things I would say on that, and it's more just a shift to suggest further listening if people are interested in this topic.
Yeah.
I mean, keep in mind that when the first DSM, when the first edition came out, homosexuality was listed as a disorder. Now, there is a great podcast on This American Life, an episode about essentially a group of homosexual psychiatrists who managed to change that. But it's interesting listening just when we think about how culture also plays into this. Another book that I'd strongly recommend is called Crazy Like Us. And I think it's called Crazy Like Us, The Globalization of Mental Illness or something like that. But it's a really interesting take on the importance of culture and context, and a bit of a critique the same way of what you're saying. Look, I'm not a psychiatrist. The DSM plays an important role. The other thing is that we don't have blood tests or X-rays for mental health the same way that we do for physical health, and that makes it really tricky to then, essentially diagnose thoughts, behaviors, um, in a way that can be operationalized. So I think that there's a very good reason as to why that the DSM's there, and it plays an important role. I think a psychiatrist who diagnoses would be better placed to talk about that. From I guess the only other thing I'd add is that from my point of view, thinking about promoting physical health and physical activity, the approaches that we take, to me are really transdiagnostic. I spent 5 years working in a private mental health hospital, and very quickly realized that I didn't need to read a lot of background or diagnosis or notes on the patient, because I realized that actually all it did for me, beyond safety concerns and potential contraindications, but actually what it did is that it put, I found that I was making sort of assumptions, actually, instead of just listening to the person in front of me. And so quite quickly realized that wasn't useful, and it's better for me to actually just talk to the person that's in front of me. And again, providing that the safety stuff's dealt with, listen to what they're saying and work from there. So, I think as exercise or physical health practitioners, I think the exact diagnosis probably isn't something we should be getting too focused on.
Put up on, yeah. And so I guess what actually works with exercise and mental health. So I think one of the things that we talk a lot about, and I think it's definitely necessary. We have like the Are You Okay Day, where we get people chatting to friends and family, if they're not feeling their usual best, or they're experiencing any symptoms of depression or anxiety, to speak up and talk to their friends, talk to their family. I think it's a really important message, but I also think these sentiments were reiterated by Gus, in terms of we're kind of moving away from developing people's resilience or coping mechanisms, giving them the tools to better manage, because as human beings, we're all going to have tough life experiences, and giving people the tools and strategies to overcome this, and better manage their mental well-being, I guess more so through exercise in your line of expertise. What actually works? What's your take on what actually works?
Yeah. So what works is in the programs that we can provide to support people, or what works in
more the principles of exercise that have been proven.
Yeah.
Yeah.
Yeah. So the evidence that we have is very strong around the benefits. But for me, what is often missing from that evidence is the how. Is that, like, how do we do this? For example, we published a big meta-analysis earlier this year in the British Journal of Sports Medicine that was led by Andreas Heisel. And Andreas re-looked at all the exercise and depression literature and was able to calculate what's called a number needed to treat, so an NNT. And a number needed to treat is the number of people that need to receive an intervention in order for one to have a clinically significant benefit. And what he found was that the number needed to treat for exercise and depression was 2, which is, if we compare that to, I think, psychotherapy, it's about 4. In other words, we need two people to receive exercise for one to have a benefit. But I think that what's missing from that evidence is the how.
Yeah.
Is the how do we do that? Because this is often from clinical trials that are done in these very controlled environments, and they don't give us the roadmap around. Okay, so what do we do? We've got someone sitting in front of us that has depression. What next? And that's where we need more what's called implementation research, which actually addresses exactly that. We need not just those clinical trials, but we need the qualitative studies that manage to sit down with people experiencing major depression and ask them and say, right, what can we do to support you? How does this work? You're here sitting in a gym. How do you feel being here? Does this work? Do you even want to attend a sort of public exercise space? Does it need to be private? Do we need a complete rethink around the environments that we're creating and we're inviting people in? So that's a long-winded but not direct answer. I mean, the other aspect that we know is around that autonomous motivation. And so that idea that we need to be thinking that if we as health professionals are simply telling people, go and exercise, it's not going to work. We've got to find ways that we can show people and that we can slowly work with them to shift that motivation, to shift that recognition. And the ways that we can do that, it might be starting very, very slow. It might be thinking about different forms of activity, and another key point that we haven't even touched on today, which we know is absolutely critical, is enjoyment. And if people don't enjoy what they're doing, they're not going to stick with it. They're not going to do it. So it's really critical that we also, challenge ourselves to find things that are enjoyable and going to spark a bit of fun and are going to, yeah, I think, in some ways we risk over medicalizing
Yeah.
exercise and activity. And actually, if we think about, well, having some music on and people dancing around and having a bit of fun, that can work and that can be effective. We don't need a white coat, the clipboard, and counting sets and reps in order to use the benefits of activity.
Yeah, and I guess also like that relatedness as well, those social supports. A lot of those, those themes that Grace has looked at in her research that with what you're doing at Addie Road. So, all those support services as well. Like, I think you're right in saying that where things are going at the moment is that implementation, that scale up research. How can we reach the most people and have the largest impact? But I also think what you're saying there about understanding the context that everyone's different. So everyone has different interests. And as you said, like autonomy, the ability to decide what you want to do, sense of competency in that you can do something and feel as though you have the skills to do that activity, not just, being thrown into something like resistance training with no idea of, what technique
Yes.
you need to use. Yeah. And then relatedness. So just like being with your friends and family
Completely. And I think, another thing you can do is work with mental health professionals because they've got these skills and expertise that a physical health or exercise practitioner may not have. Now, again, thinking about that workforce issue and bringing these two workforces together, imagine if we had joint sessions.
yeah.
Imagine if we had sports coaches that also had or sporting organizations, but also there was a mental health officer or person involved as well. And the idea about how do we almost reimagine what these workforces of the future look like and the skills that they need and how we can utilize the skills of other disciplines.
Yeah. And so you're one of you. I was looking through Google Scholar, and one of your most highly cited first author papers was a systematic review in 2014. So I think it's had about 890 citations, and that was published in the Journal of Clinical Psychiatry. And you basically reviewed all the physical activity interventions for people living with a mental illness from earliest ever recorded to 2013. You looked at all those major databases like Medline, Embase, PsycInfo. You didn't look at eating disorders or dyspnea, which is like chronic depression, I think. And you looked at all of them were randomized controlled trials, but they weren't just exercise interventions. They included also, counseling and, like lifestyle programs as well, not just based around specifically exercise. Can you tell the listeners a little bit about what your, I guess, main findings were that came out of that systematic review and what major takeaways are?
You're making me sweat here, Hayden. So just, I mean, I'm impressed with the background, but that was, yeah, you're absolutely right. That was done in 2013 and published in 2014. So that was no, you were correct. I'm just laughing. I haven't spoken about this for a while. But yeah, that was my review I did as part of my PhD. And it was a really, interesting process for me because was able to just completely immerse myself in all the literature to date, and a meta-analysis is obviously, for those that aren't
Big job.
interested in the boring science stuff. Yeah, we take the raw data from studies and combine it statistically. And there's obviously been far more since we published that. So that's, now, it's outdated now. But essentially what we did and what was different at the time is that we didn't look at so what we did that was different was that we looked at the antidepressive effect of exercise, but across all mental disorders.
Right.
So you're spot on. We excluded eating disorders, but we included things like schizophrenia because we knew that exercise can improve depressive symptoms in people with schizophrenia. And we included anxiety, we included major depression, and what we found.
Sorry.
Yeah, sure.
Can I ask why you excluded eating disorder? Was it because the fact that it was based more around, they were centered more around the food they were eating would likely not be influenced by the exercise, or exercise would have more of an inhibitory effect on the actual condition?
Yeah, so I guess if we think about just coming back to what I mentioned about working in the hospital, and I was working in the hospital at that time.
Yeah.
And that idea that I mentioned before about not wanting to read the diagnosis of patients, and seeing firsthand that actually whether they, no matter what that diagnosis was, and again, I'll come back to the eating disorder thing,
Yeah.
but that exercise could be effective. And so the approach to the meta-analysis reflected what I was seeing in the hospital at that time.
Yeah.
And it was the idea that it didn't matter about the diagnosis. What I was seeing was that this looked like there was an effect and that this was positive. The reason we excluded eating disorders was because there's an added layer of complexity there, in the presentation and in the relationship between potentially compulsive exercising, and also the nature of eating disorders as an illness, and the relationship with food, with nutrition, with lifestyle factors that makes it just a different factor. And there are people that are specializing in that area. There is evidence around that. So Alana Riley, I think it is an exercise physiologist doing great work around eating disorders. Michelle Probst, who's the founding president of the International Organization of Physical Therapists in Mental Health. He did amazing work around eating disorders and exercise in Belgium. So there's people doing that work. We felt that because of the complexity of that illness and the different relationship with exercise, it was fair to exclude that from that review.
It makes sense, yeah, because if someone's got anorexia nervosa, they would be exercising to eat into their calorie deficit to lose more weight, I guess. So exercise for someone with depression, anxiety, which could be used as a tool to improve their health, for someone with that anorexia would almost be like a hindrance or something they'd use to worsen their condition.
Yeah, and if we think about the approach as an exercise practitioner, if you've got someone with, let's say, depression or schizophrenia or anxiety disorder or PTSD, then overwhelmingly what you're dealing with is symptoms that relate to poor motivation, that relate to fatigue. So the approach is going to be around motivation to exercise and trying to create those, that motivation and support people. That's going to be a very different approach compared to working with an eating disorder.
Okay, and I guess with Grace as well, she's currently your PhD student. We just talked a little bit about some of the research she's doing. I think we mentioned a bit earlier in the podcast. She's currently doing a 10-week online intervention. So she's got some Facebook groups. She's got diet and physical activity intervention that's working with emergency service workers. Can you tell us a little bit more about that in particular study?
Sure. So Grace is a postdoc. Grace is finished.
Oh, okay.
Um,
She's all done.
so it's yeah, it's all done. Academia is always a bit it seems like it takes time for stuff that's available online, but it's Dr. Grace, and I'll just flag she won the ESSA medal for her thesis
Wow.
in
Yeah.
last year, which was great. So Grace has done some brilliant work using digital technology and thinking about how can we think about physical activity promotion in specific groups. And Grace worked with emergency service workers. So that's a group at high risk of occupational trauma, being exposed to stresses at work. So high risk of PTSD. And what Grace did was using a closed Facebook group, invite emergency service workers. But importantly, we also had peer support workers. So they were emergency service workers with lived experience of being an emergency service worker, but also of experiencing PTSD. And they were acted as like peer health coaches alongside the EPs that facilitated the intervention. Um, and we've now published that the results from that trial was very promising. The outcome was very positive, and just showed the importance of creating that safe space, creating community, thinking about other forms of knowledge, that lived experience, how critical that was. Grace and I aren't emergency service workers, so as much as we can read about it and we can try to empathize, we haven't had that experience.
Yeah.
So, of course, someone who has been through that, who's maybe struggling, um, talking to another emergency service worker who's lived through that, who's come out the other side, who is far more relatable. Um, so I think there's a real opportunity to think about the groups that we're trying to work with. How can we find, yeah, those champions or advocates or people with experience from within that we can work with?
As the Australasian Society for Traumatic Stress Studies, as you're the president currently, this is an organization with over 600 healthcare professionals that are expertise in the treatment and prevention of trauma. I guess being the president and all of the work you've done to date, based on what we just discussed there, looking at emergency service, I guess, workers being a high risk population, which particular groups aside those emergency services have you found to be the most at risk of different mental illnesses?
Yeah, I mean, if we think about trauma in particular, there's lots of different groups. There's veterans, emergency service workers. There's people working in high pressure environments in the prison system. There's healthcare workers, social workers, people exposed to vicarious trauma, gender-based violence workers, people working in legal aid. The list goes on around potential exposure to psychosocial stresses at work, who may benefit. So, just to note with ASTSS, we, thanks to Grace, we have an allied health special interest group focusing on nutrition and exercise. I've been really grateful to ASTSF for their support in recognizing the work that we do, and it's been a real opportunity to try to advocate and ensure that exercise and lifestyle factors are considered at the forefront and are there alongside other treatment modalities. We're currently planning the ACOTS conference, which is the Australasian Conference on Traumatic Stress, which will be, I think, in Melbourne in November next year. But there'll be a big focus on activity and on physical health as well. So it's been, a real honor for me to be able to be involved in that organization, given that I'm not a psychologist, I'm not a psychiatrist, but to be able to come from the background I do. And I think it's, hopefully there's reasons to be optimistic if there are other, EPs and physios that are interested in this space. I think there is there's a lot of momentum and a great group of people interested in this area. So I think, I'm really optimistic about where we'll be in 5-10 years time.
And in the preceding years after you wrote that, you did your thesis, that systematic review we just spoke about. You co-authored a book with Brendan Stubbs, textbook, exercise-based interventions for mental illness. And in that book, you basically covered all the common mental illnesses and you looked at their pathophysiology, and then you provided a really simple and easy to unpack justification and specific strategies for each of these different conditions. So one thing that sort of I wanted to ask you, I've talked a little bit about anxiety, depression, and then we've had trauma as well. And I've kind of bounced between those interchangeably. But is there any difference in the way you would prescribe exercise for each of those different conditions? So I guess trauma versus anxiety or depression. Yeah.
Yeah, it's again a great question. I would say that we sort of think about it as levels or a bit like a pyramid. So I would start broadly thinking about understanding the different diagnoses and what they mean. And then when you get down to the specifics with the individual in front of you, it sort of changes. Yeah, it's about the unique factors for that person. So the evidence that we have, again, is very strong for depression, for anxiety, for trauma-related disorders as well. Some of the practical exercise considerations, if we're thinking about PTSD or trauma, just might be around potential triggers for people, and the same with anxiety as well. But that comes from understanding that individual. And again, I think it's actually more important about creating a space, an environment, and a relationship with that person where you can have those discussions. There's a lot of stuff around trauma-informed care and trauma-informed approaches, and a lot of it's really important, and I think it's really important that we get our heads around that and that we understand that. I also think that there's an importance of thinking, what do I need to do with the service I'm providing to make this safe for everyone. And I think if we start there, that we can often do a lot more than we realize.
Yeah, I think it's definitely, for me, what I'm kind of taking from this is it's less so about the actual principles, but more so about the person. So, you can understand the pathophysiology of the actual condition or the illness, which is really important, but it's less so about treating the condition, more so about treating the person, if that makes sense.
It's cliche, and I'm not giving you anything groundbreaking, unfortunately. But yeah, you're spot on in how you summarize that. I think the person-centered stuff is absolutely critical, and also our own stigma and our own views that we may not even realize we have. But trying to unpack those is a really great place to start.
And so that's something also really important to discuss there is, so for instance, if someone's living with diabetes, we're through Diabetes Australia, we're taught the person living with diabetes, the condition doesn't define them as a person. So they're not a diabetic. So we don't call them diabetics. We call them people living with diabetes. So I guess I've tried to apply that to all conditions, but in the same sense, you don't say that someone living with schizophrenia, they're a schizophrenic, or is that something that you've learned to apply? Maybe you can educate others.
Absolutely.
Yeah.
People are not their illness. Yeah. So we don't refer to people as their illness. It's people living with. That's absolutely critical. There's also a big movement within the mental health world around, social justice and about the idea that nothing about us without us. And I think that's a brilliant line, which shows about the need for autonomy and the need for people to have a seat at the table in discussions about work that's happening with or about them. So, and that's had a big part into, the work that I do with refugee communities or with people living with mental illness, is that, I'm working alongside these people as partners. I'm not um, making decisions about people. I'm again bringing the little bit of knowledge in one area I have, and then trying to combine that with the knowledge that the people that I'm working with have, and seeing what do we come up with. So I think it's really important for us to take that approach, and it's the idea of that we're partners in recovery. We're not we're not dictators.
Yep. I agree. And, probably in the last 10 years, we've moved away from, when you were in primary school, we used to, if a kid was annoying you or something, you might call them gay or something, and you didn't think anything of it. Now we understand that's completely wrong. By the same token, though, how many times have you been in a school or in Australia, been around a group of teens or, even adults for that matter, who have referred to someone as being crazy or she's a psycho? Can you maybe provide a bit of awareness for the listeners on why we should be avoiding labeling people by those terms and how much damage it's doing to the work that a lot of psychiatrists and psychologists are doing, and people like
Yeah,
yourself in this space?
yeah, it's a really important point, but it comes back to that safety aspect, um, and it comes back to power. And it might feel harmless, and it might feel that those terms are, um, don't can't, that we understand as a joke, and that's it's a very Aussie culture thing as
Yeah.
well, isn't it? But we don't know. I'll just come back to what you said at the start around, you didn't realize how many people in your world had been
Suicide.
touched directly
Yeah.
by poor mental health or suicide. So if we're then using words that we, like that, we don't know necessarily, even those close to us, how that might land or how that might have an impact. So, it is cultural. We do become aware of this over time. Um, but I think, yeah, language can be super important, particularly coming from a dominant group. So as health professionals in particular, got to be super careful that we're not isolating people.
Yeah, and I think particularly the youth, not only are they a population that's at risk of mental illness themselves, but I think they're an important demographic to educate on this issue. We know that around 14% of children and adolescents currently experience some form of mental illness. So the 2017 census, which is 6 years ago, but I imagine it's the number's grown a lot since then as well. But around 600,000 adolescents or children across Australia have been diagnosed with a mental illness. So particularly another high risk population. Would you put that down to the rise of social media and increasing use of technology, entertainment and news? Is there any other factors that we're discounting or we should be starting to think about?
Oh, there's people far better placed than me to talk about that. I think you've got a range of factors coming together. So yeah, we do have social media, we do have internet, we do have 24-hour news cycle, we do have interrupted sleep, we do have changing diets, we do have a rising inactivity. So there's all these factors that are related. The the important thing there, I think, as well, is that that awareness piece that you mentioned. Um, there's some great work just thinking about schools and stigma, but some other really interesting work happening. So Stuart Vella is an Australian researcher doing very interesting work around sport and mental health, but thinking about what needs to happen to make sporting clubs and sporting associations better placed to support and address. And they've got a great program called Ahead of the Game that's being rolled out. So I think there's really interesting stuff happening about thinking, how do we take mental health to where people are, so to sporting or youth organizations, to the community, not just within a mental health facility or a clinical environment. And that, I think, for me, is one of the most important things going forward about how we sort of change the narrative and create systems and structures that capture people early. Because we know that early intervention is absolutely critical, especially for children. The earlier we get in and the earlier we get support, the better people can be.
Is there a consistent trend across, like, internationally, I guess, amongst those children and adolescents? I guess the burden of mental illness, is it completely different here in Australia?
Yeah, look, again, I'm not best placed to answer that. I would say my sense around Western countries is that we're quite similar, but I haven't looked at that epidemiological data, and I do know there's been, a bit of there's different ways of looking at the impact of COVID as well. There's been a big impact there. So I think I'd be reluctant to comment too much on the epidemiological data around prevalence, but I can say that again. I think there is a contribution of those modifiable lifestyle factors, and we've got a long way to go in terms of things that we can be doing to be improving those.
One thing you can comment on, though, is the Olympic Refuge Foundation. So, non-government organisation that was founded in September 2017. So, relatively recent, by the International Olympic Committee, and they're based in Switzerland. As I said, you're the co-chairman for the think tank on sport and displacement settings there. Tell us, we just spoke about youth being an at-risk population. How are displaced youth refugees impacted by post-traumatic stress? And what kind of work are you doing with this foundation?
Yeah, so the ORF, I'm really excited to be able to talk about this. So the ORF or the Olympic Refuge Foundation. If we think back to Rio in 2016, there was the first time that we had refugee athletes participating under the banner of the Olympic refugee team. And the ORF was set up to support the refugee athletes, but also to provide advocacy and work around the role of sport in displacement settings. Now, we have over 100 million people displaced globally at the moment. And that, if you look at world events and what's happening in the Middle East now, I mean, this is not, this is getting worse. And there's also the impact of climate crisis. And I mean, human displacement, forced displacement is an enormous issue. My interest in this area came from work I've done in Bangladesh, working in the Rohingya refugee camps, which is the biggest refugee camp in the world, and seeing firsthand the benefits and the importance of sport, even in these, extremely in these communities living in extremely adverse conditions. Closer to home, if we think about Australia, think about when there's natural disasters and how communities often mobilise around, arranging sausage sizzles at the local park or something, or what happens there, the way community gets together. Sport is a part of that, kicking a football around, the impact on children that it can have, and the fact that sport is this transcultural thing. And I've sort of used this line that if you give a kid a ball, they're going to kick it and they're going to look for a friend to kick it to. And I think that sums up actually the power and value of sport. So the ORF, obviously through the Olympic brand and Reach, is doing fantastic work in this area, not only supporting the Olympic refugee athletes, but also in programs all around the world, but also in providing leadership and advocacy and tools and guidance around how we can utilize sport in humanitarian and displacement contexts as part of the mental health strategy. And what's been really interesting for me is seeing the recognition within the mental health world around sport and how that's now changing, and we're seeing tools and guidance, and I don't think where I think it's going to go and where I see it heading is that you will have as part of a mental health team working in humanitarian or crisis environments, you will have a sport specialist as part of that team who understands how to utilize sport in a safe way to focus on participation, not on competition, which has been the traditional focus, to focus on groups who don't have access, people like women in a lot of these environments don't have access. Yet people living with disabilities, there's lots of scope and lots of room for us to do more.
Yeah, we spoke about before we came on air again about the 10 scholarships that have been offered to 10 refugees to train towards the Paris Olympics in 2024. Now, do you see yourself playing a hand in any potential success stories at the Paris Olympics?
No, no, I wish I did. No, so I don't work with the athletes. So my role is through the think tank,
Yep.
which is focused on, again, the tools and resources, the guidance, the advocacy work, but really looking at how we utilize sport in humanitarian settings.
Yep.
The athletes are obviously the ones with the incredible stories, and again, we've talked a lot about knowledge and different types of knowledge. And those athletes with lived experience of forced displacement just have these incredible stories to share that can be so powerful and motivating and inspiring for people all over the world.
All right, mate. Well, it's been an awesome chat. Just to wind things up, I want to go into detail a bit about how you actually got into exercise physiology. Were you a sporty kid as a youngster?
I was a climber, so I was a competitive rock climber back in the days where in the under 18 category we had about four of us in the competition. So, I knew exactly where I was coming, which was fourth. But, so that was before it was an Olympic sport. But that was, yeah, I mean, I just loved climbing. And so for me, it was wanting to train and understand more about how I can train. So I thought I was going to work with elite athletes. That's what I wanted to work with. But that very quickly changed once I got exposed to the other opportunities. Yeah.
And did you fight any mental illness, any challenges growing up? Was that one of the reasons why you gravitated towards working in this space, or was it something that kind of just eventuated as you went through university? You were kind of in the right place at the right time,
Yeah, look,
right
what
people.
sparked it for me was getting the opportunity to work at a hospital, a mental health facility, and that was by chance. Um, so, I turned up there knowing absolutely nothing. I had my own stigma, my own concerns. They then, handed me a dressel and shoved me in this gym. And I was terrified, if I'm honest, about what what was happening there. And that's what sparked it for me. And then working with people, particularly with veterans at that time. So I had a lot of vets coming in who to the gym, and they would do a session, and they would just be very honest about how there were a few of them in particular that exercise kept them alive. That if they weren't able to train, they wanted to kill themselves. And these were hospitalized vets with severe PTSD. And so I was really confused because I was seeing that firsthand, but then I was looking and there was no funding for exercise services for PTSD because I was told there was no evidence that it was effective. But I became just incredibly passionate about that area because I was just seeing it firsthand and seeing the disconnect between what was happening in the hospital and what patients were telling me versus what was available and what was actually funded. And to me, it was a real sort of, yeah, almost an injustice around, well, hang on, these people are so passionate about, or not passionate, but are telling us this is so important to them, but yet we're not listening, and we're not funding it. So why is that the case? So that's where I guess it sparked for me the idea about, well, essentially making my work and the focus of my work, how do we get more people access to this?
Yeah. Now, is there any particular role models or mentors along the way? Like, I guess for Grace, that's you, but like for yourself, was it your PhD
Yeah,
supervisors or?
I've been really fortunate to have amazing role models. So it started with Professor Kathy Sherrington at the George, and then Professor Ann Tiedemann at the George, and they were incredible. Then I met Professor Phil Ward from UNSW, and he was a neuroscientist who, as he jokes, got distracted by exercise. And Phil and also Professor Jackie Curtis, who's a psychiatrist. And I worked very closely with Phil and Jackie. And if it wasn't for their mentorship and support being within the mental health world. I wouldn't have been able to do anything that I'm doing now. And then also Professor Zach Steele, who's a trauma expert, and it's really been their vision, their guidance, their um, you know unwavering support that has allowed me to do the work that I'm doing, because they have they're in that community. I'm not a psychiatrist, I'm not a psychologist. There's only so much I can say, but I've been very, very fortunate, and plenty others as well. And then also my colleagues that I've been fortunate to work with: Brendan, Davey, Van Camport, Felipe Shook, Joe Firth. They've been an incredible group of just relentless, relentless researchers trying to make a difference, and trying to spark that evidence base, but also to just advocate and the recognition around that this can be important and to change things.
In all your travels, Simon, abroad, what are some of the biggest challenges, run-ins, memorable moments you've had? Could be, the biggest pickles you've had. What? Give us some of your most memorable.
Yeah, it's tricky. I mean, it's been really, largely it's been very fun. I love, I was in, as I said, Jakarta last week and meeting students there, and had this great, day at the university. But, I did a talk, but before my talk, there was like a 1 hour ceremony that involved singing, and the students were. It was, I mean, it was amazing to be there and to be able to spend some time with the students. That for me is the best thing, is actually meeting students and practitioners and from different countries and seeing different ways of doing things. Um, every time it does just reiterate how lucky we are in Australia, how much we have. There's obviously a lot of issues in Australia, but it's also one of the luckiest countries in the world. We've got so much to be grateful for. Our healthcare system, for one. So the fact that we're even in a position where we're talking about exercise as a healthcare thing, like, just puts us miles ahead of so many other places on earth. Um, whenever I come home, being able to walk out of my apartment, walk down to the beach, or just walk outside at night and not think about, security or safety, that is something I'm incredibly grateful for. Turning the tap on and drinking water out of the tap, things that a lot of the world doesn't have access to. So we are incredibly lucky. And I think I'm not giving you events, but I guess it's just the reflections about what it always makes me feel around Australia, and the pride and that I have of being Australian and from that place.
What about the best countries?
Best countries. Look, for me,
Colombia.
work-wise,
You mentioned Colombia.
yeah,
Yeah.
Colombia for sure is you know for me, there's just so many things happening here, and there's also a very complicated history and a very violent history. So the sort of social situation here, which I won't even pretend to understand, but the more time I spend, that I'm just scratching the surface. But how that influences the practitioners that are here and their training and their view of what they can do and the role of their work, that I find super inspiring and super interesting. Bangladesh as well. I've been really fortunate to have very close working relationships with a lot of mental health professionals in Bangladesh. Those that are working with the Rohingya community, in a really difficult situation. You've got 1 million refugees that have been forcibly displaced from Myanmar. There's very difficult situation, and the health professionals that have gone there to work and to try to support that. Um, yeah, so I get quite inspired by the creativity of people in situations where there's less resources than we have in Australia, because you realize that when you give when people have less, they have to sort of do more, and they've got to think in different ways. And it's really inspiring to see.
All right. And the last thing I'm going to ask you, now I've created a bit of a Spotify playlist for the Normless podcast. So every every guest can give their their favorite banger or their favorite tune. Now we've had a few. It's quite a mixed bag. I don't know how this playlist is going to look. It's no real set genre to it. It's because I had Lee Priest, who was on previously, and he's put an Elvis Presley song on there. Then we've got some old school '90s R&B. What's your favorite tune or one that you might have been listening to recently that you would throw in the playlist that kind of epitomizes some of
Well,
what you listen to?
I love it. Okay, so I'll tell you who I've been like I just can't turn off at the moment. Um, is Michael Kiwanuka. Um, and there is anything, every single one of his songs is just brilliant. But there's an album, Love and Hate, which I just can't turn off. So that's where I'd be adding something from there for sure.
Right, I'll go to the top of the most popular song at the top of that album. That
Let
one.
me. I love it. It's a great question. Go with Cold Little Heart.
Old Little Heart. All right. It's in. All right.
Beautiful.
Plug your socials for us, Simon, so the listeners can find you. Instagram, Twitter. I nearly said Twitter again. X.
Yeah, X. I think I mean I'm most active on X. I'm not so good on the others. LinkedIn as well. There is Instagram, but not so good. But I'll pick that up. But happy to chat to anyone. Keep the conversation going, and very interested in any thoughts or reflections. Please get in touch, and thanks Hayden for the opportunity. It's been great to chat.
No, it's been a pleasure, mate. The work you're doing, it seems like you're getting so much fulfillment out of it, and you can tell you're really passionate. So I've really enjoyed this chat, like thoroughly, really enjoyed it. So thanks for your time.
Thanks so much. Likewise, it's been great to talk. Cheers, Hayden.